See.
Good evening, President sir.
How are you, boss?
Fine, sir, fine.
Yeah, it's 7, sir. We'll start.
Okay, okay.
Good evening, Dr. Suresh.
Yes. Yes.
Good evening, sir. Good evening.
Yeah, good evening. Yeah. Hello, sir. Yours. Yeah, we'll start, sir. Shankar, sir. A very good evening to one and all. I heartily welcome all the members of API, ICP Karnataka and other members of various organizations who have joined virtually from all over the country to attend this program on World Tuberculosis Day. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus, RGHS and KBN University, Gulbarga. I welcome our other guest of honor, Dr. Muruganathan, who will be joining shortly, who needs no introduction. Presently, the Director PR of API, past Dean ICP and the past President API, and he was the past Governor ACP India chapter as well. I also welcome our own committee members, Patron API, Dr. Maya Sir, Dr. Suresh Sagara, Chairman, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, and Dr. Srinivas Murthy, Central Committee members. I welcome our today's chief guest, Professor Dr. Jyotirmay Paul, President National API from Kolkata, who never said no to any of our invitation, that speaks his dedication and commitment to academics and API and teaching and training the youngsters. A great academician, researcher who has taken national API to an international level by doing great academic events, a great name in the API family in the country. Let us not waste time by reading their CV profile, which runs in. I also welcome our today's speaker, Professor G.C. Gilnani, pulmonologist and chairman, PSRI Institute, Delhi, and ex-HOD, All India Institute of Medical Science, Delhi, a great name in the field of pulmonology in the country, with many publications, both national and internationally, a great scientist, researcher, and a clinician, a teacher par excellence and teacher of teachers, heading the prestigious Institute of PSRI in Delhi. I welcome our today's moderator, Dr. Agam Vora, chest physician from Mumbai, a dynamic personality, Secretary General of API India, who has taken API to great heights, both nationally and internationally, a great academician, clinician, and a researcher with many publications to his credit. I welcome our today's panelist, Dr. Harikishan. He is the lead pulmonologist from Yashoda Hospital, Secunderabad, a dynamic young interventional pulmonologist known for his interventions in various procedures and handling complications as well, with many researchers and publications. I also welcome our other panelist, Dr. Samir Bansal, pulmonologist from Apollo Hospital, Bangalore, who is working with Dr. Ravindra Mehta, a great name in the pulmonary medicine and a good rehabilitation center as well, doing a lot of procedures and research work and publications. Lastly, I welcome our own senior colleague and faculty, Dr. D.P. Singh, chest physician from city of Bhagalpur, Bihar, an active member of API family in the country from past many years, representing all capacities like ICP, PRF, and various other committees. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म
We are virtually honoring all the faculties as well. Yeah, now I request our President, National API, Dr. Jyotirmay Paul, to address the gathering to say a few words for his word of wisdom. Over to you, Dr. Jyoti, sir.
Good evening. I congratulate entire FEI family and API Karnataka branch on the occasion of World Tuberculosis Day. Today I am very glad that the entire country, our all state branch, city branch, have observed World Tuberculosis Day with different activity across the country. World Tuberculosis Day basically is the day on which the Robert Koch discovered the Mycobacterium bacilli. Previously, it was a thought that it is a curse of the god. And this disease is present for 4,000 years. There is evidence even in the Egyptian mummy. Till, in spite of discovery of so many drugs, so many diagnostic avenue, we fail to eradicate this disease. At present, 25% of the world population have tuberculosis, and 10% there is a conversion to the active disease, and 15 lakhs death per year annually. So imagine the huge burden of tuberculosis. On the top is added the issue of drug resistance tuberculosis, multi-drug resistant tuberculosis, extended drug resistant tuberculosis. So these days special to the physician and the people because it's giving a reminder that the awareness of prevention of disease and removal of all the misconception regarding the treatment of tuberculosis is very much necessary to prevent and to reach the goal that is set up by Government of India, WHO 2030 and Government of India by 2025. At least we have to reduce the 80% incident and 90% complication and mortality. This should be our primary goal. So to reach this goal, there is a awareness of the physician regarding the correct diagnosis and treatment of tuberculosis, and we have to work at the grassroots level. So the spread of the disease, awareness of the disease increases. And I am very happy again and congratulate API Karnataka branch to take such an initiative. And this initiative should not be taken only on this day, 24th March. This should be 365 years. Then only we can reach the goal set up by our Government of India. Thank you. Thank you. Thank you, everybody, and good evening. Wish all success of today's program. Thank you.
Yeah, thank you, sir, for sparing your valuable time. Now I request Dr. Professor P. A. Shankar to address the gathering. Kindly unmute, sir. Unmute.
Jyotirmay Paul, Dr. Muruganathan, Dr. Maya, Dr. Suresh, Dr. Sinivalar, Dr. Agam, Dr. Kelani, and panelists, and the office bearers of the APA, our colleagues and friends. We have met here to celebrate the 43rd World Tuberculosis Day, commemorating the date in 1882, when Robert Koch announced the discovery of the causative agent of tuberculosis. This month it also happens to be World Women's Year. And we have to not only the Koch was a practitioner in Germany. His wife gave him a microscope because he had to go on working. So because of that microscope, he could discover this tuberculosis. So the credit also goes to the wife. And at the same time, Germany also contributed for all. Jill Nielsen, they are also from Germany. Ranjan X-ray, which is used for TB, they are all from Germany. So the only later, the French, this vaccine came in 1921. So the credit goes to Germany only. So I am happy to see the leading names, Dr. Agam and Dr. Kilmani in the group that is taking part in the program. Tens of millions of people are falling ill with tuberculosis, and million people are dying each year with this preventable and curable disease. The TB deaths and the disease have increased. There is an urgent need to dramatically increase the action and investment to ramp the fight against the tuberculosis and achieve commitment to end TB. The theme for 2025, yes, we can end tuberculosis, and commit, invest, and deliver. And it is a hope, urgency, and accountability, a call for optimism accountability, and resolve. A commitment has been made during the United Nations high level meeting in 2023, pledging to accelerate the efforts to end TB. Now, a real action is needed for rapid implementation of the WHO guidelines and the policies strengthened by the national strategies. We are also aware that TB cannot be defeated without investment. A bold, diversified approach is needed for fund innovation to close gaps in the access to tuberculosis prevention, treatment, and cure. Lastly, delivery has to take place. WHO has recommended interventions such as early detection, diagnosis, preventive treatment, and high quality TB care, particularly for drug resistant tuberculosis. Hence, it has called Commit Now, Invest Now, and Deliver Now. Together, yes, we can end tuberculosis. The WHO Director General flagship initiative to fast track the progress towards ending tuberculosis over the period 2023-27, the focus is on the ensuring universal access to prevention, care, and the use of latest tools and technologies to combat tuberculosis on the road to the universal healthcare coverage. In its launch in 2018, the initiative was Find, Treat All, and End Tuberculosis. WHO has recommended TB preventive treatment options, shorter TB treatment regimens, rapid molecular diagnosis, and tests for the tuberculosis infection, and digital tools that will lead to improvement in the health outcomes, and the TB research and innovation, particularly for new vaccine development, as the initiative covers a period for 5 years from 2023-27 with a milestone of 2025 this year, matching the middle of the end of TB strategy. It will take us toward the health-related sustainable development goals, including for tuberculosis. It has stressed universal access of tuberculosis treatment for all 90% of people, for rapid diagnostic tests, preventive treatment, financial risk protection for the vulnerable people, license to a new TB vaccine to accelerate tuberculosis incidence decline. Sustained and adequate financing for tuberculosis services and TB research and innovation has to be done. The initiative calls for 5 strategic approaches to drive action to get back on the track, enabling the process for life-saving TB prevention and care, and on advancing research and innovation to break the trajectory of the epidemic. The priorities are engage, accelerate, align, account, and advocacy. Without early diagnosis and treatment, the death rate from TB disease is high. Reduction in the number of TB deaths is one of the 3 main targets of WHO and TB strategy. There should be universal access to high quality TB diagnostics for new and relapsed TB patients, and they are to be tested by using rapid tests such as rapid molecular assays. They have high diagnostic accuracy than the sputum smear microscopy and will lead to major improvements in the early detection of tuberculosis and drug-resistant tuberculosis. Everyone is looking forward for a new TB vaccine to accelerate the TB incidence decline. No new licensed vaccine since BCG 1921 has come. Thus, reaching end TB targets requires major technological breakthroughs by 2025, such as a TB vaccine that is effective both before and after exposure, so that the rate at which the TB incidence falls can be dramatically accelerated. The theme for the current year reflects the understanding that ending TB requires a united, concerted global effort with a strategic collaboration. Above and beyond what has been done in previous years, we are together in this effort to end TB, the oldest airborne pandemic that continues to threaten the global health and kills more people than any other infectious disease. By committing to action, investing resources strategically, and delivering high quality care and prevention, yes, we can make history by ending TB. We are eager to hear the talk on overview of TB, PA, present and future, from my esteemed friend Dr. Kilnani, to be followed by panel discussion moderated my very good friend Dr. Agam. My special thanks Dr. Sangram for organizing this program. I'm happy to associate with the inauguration of this program and wish the program all success. Thank you.
Thank you, sir. Thank you for your words of wisdom and overview of tuberculosis disease. Now I request our chairman, Dr. Suresh Agarwal, to say a few words.
Thank you, Dr. Sangram, sir. It's great beginning this year with a couple of CMEs under your leadership. Karnataka API and ICP wing is becoming a forefront of API Central, and we are carrying out the vision and directives of Central API. And rightly, Dr. Jyotirmoy Paul and Dr. P.S. Shankar have already highlighted the importance of TB and its prevention and treatment. And I think without wasting much time, we will wait for our expert panel led by Dr. Kidlani to address these issues. Let's begin the talk. Thank you, sir. Thank you very much.
Yeah. Thank you, sir. Now we move on to scientific session. I request our moderator, Dr. Agam Ora, to take over for further proceedings. Since all faculty have been introduced, over to you, sir.
Good evening, everybody, and thank you, Sangram sir, for arranging this program. And look at this, your CHAM, it has become absolute national event. I can see a lot of people across the country already joined. And of course, it comes to me with no surprise when Dr. Shankar sir agrees to be at the program. And we have the fantastic speaker, you have the fantastic panel. So I would request Dr. Khilnani sir to please begin with his scientific session.
So good evening, ladies and gentlemen. I'll be sharing my slides and just a second. Yeah. So is my slides visible and I'm audible?
Yes, sir, it's visibly audible.
Thank you very much. So good evening. First, the outset, it's an honor for me to be with you, and thanks to Dr. Sangram Biradar for inviting me. And it's a double honor because on World Asthma Day also I was there. And what to talk about Dr. Shankar? He calls me a friend, but actually he's like my. And of course, a lot of friends are there, and Agam is ever so dear to me. But when Dr. Sangram asked me to talk about past, present, and future of tuberculosis, I felt very, very small actually. I know that all the physicians are the senior most physicians. So I really don't know whether I'll be able to give something which is meaningful, but I've tried my best to go into the history and tell about less about the present and little bit talk about the future. And I'm looking forward to a vibrant panel discussion. And believe me, when you join a group and make a presentation, the most learning is for the person who is presenting, because he has to prepare it and then get opinion of everybody. So thank you very much. So as Dr. Jyotirmoy Paul has said that tuberculosis is not a new disease in the Egyptian mummies. In the spinal tuberculosis with this psoas abscess was seen. And in India, there are references of disease resembling tuberculosis in ancient scripture text as Athar Veda and in Ayurvedic writing also. And disease was called as something like wasting, and various names were given, kappa, something, which were, and I don't know how the patients were managed, Going through the literature in Europe in 17th and 18th century, 1/4 of the deaths were caused by tuberculosis. In the United States, 1/6 of total deaths were caused by tuberculosis. So, is it the socio-economic development which goes along with tuberculosis, which has several names like phthisis in Greek, tabes Latin? The cervical adenopathy was called scrofula, and 17th century people referred it as white plague, later on as consumption. It was Schonlein who actually named it as tuberculosis. And in India, there were several sanatoria. The first sanatorium came in 1905. This is Tambram and Kasoli. And of course, the great man. Today I came to know that it was wife who gave a microscope to him, but he's the one who actually, while the scientific fraternity knew of tuberculosis, that vaccine BCG was developed much before, but nobody knew what is the organism. And this great man actually, the invention of Mycobacterium tuberculosis, actually changed the game of tuberculosis. And then BCG vaccine, which came in 1921, and this has not changed the game, but still we believe that it is a useful entity for us. And the breakthrough came when the Professor Salman Waxman, he was experiment with streptomycin, going into the history. And his colleague who was treating a 13-year-old girl with tuberculosis, he borrowed few vials from him and treated that girl with streptomycin alone. And later on, she was cured and she married and delivered babies. And that time there were no ethical clearance, no DCGI or something. So that's how streptomycin was proven to be curing tuberculosis. And if you talk about global trends of tuberculosis, there has been decline all the time. But during COVID time, since the reporting was not there, and then subsequently the reporting came, there was increase. Seemingly, there was increase in tuberculosis. Similarly, you can see here the rates per 100,000. There's a decline in the during COVID time, and as the reporting increased, it kept on increasing. So the worldwide the tuberculosis incidence is actually not decreasing. 10.7 million to 2022 to 10.4, then 21, 10.1 million. There's only minor decline. And there has been a reversal of downward trend that had something to do with that. If you talk about countries like majority of tuberculosis is in India, Pakistan, Nigeria, Indonesia, Bangladesh, Philippines, China. Something to do with the development. And in 2023, 8 countries accounted for more than 2/3 of tuberculosis, and I have already recited the names. And the MDR tuberculosis. When I wrote my first review article in the year 1995 on MDR tuberculosis, I came across certain editorials from India which said MDR is a death sentence. But thankfully, MDR is also coming down, and but it's not so low. The estimated proportion of previously treated MDR is from 20% to 16%. And between 2020 and 23, there was estimated increase in the number of people who developed MDR. Probably it has something to do with the reporting because of the COVID. And if you look at the primary MDR, it is coming down. The secondary MDR is coming down. And I'll talk about the newer regimens soon in a brief, which are actually a sort of silver lining and light at the end of tunnel, which can So this is the summary. The 2024, 1.25 million new TB cases were there, 161,000 deaths were also there, and it is deplorable. And as far as the MDR is concerned, that is also causing sufficient havoc. Now, the India has gone ahead, and Prime Minister actually declared that we'll remove the tuberculosis by 2025. In 2015, to reduce the estimated TB incidence, it was reduced. It was targeted to make it 77, but achievement was 199 per 100,000. To reduce the mortality, the target was 6, but we achieved 23. To ensure that no family should suffer from the cost, that was targeted at 0. But long way to go for this, and the India is progressing well on tuberculosis. There is a 16% decline in estimated TB incidence has been observed from 15 to 22, but I think it is suboptimal. And there is also 18% decrease in the TB mortality from 2015 to 22. So what is the worrying point? Worrying point is that there are 35 to 40 crore Indian population who have latent tuberculosis, which is a big deterrent to control of tuberculosis, because 5 to 10% of these people at some point of time would develop active tuberculosis. So is there a need to focus on this? So therefore, there has been, starting from National Tuberculosis Program, and I don't need to go into all these programs, but now we are talking about tuberculosis elimination program, and that is an enthusiastic program by the government of India. Now, I'll be briefly touching upon advances in the diagnosis, and lastly, I'll go into the artificial intelligence. The gene expert, or net, or TrueNet, whatever you call it, is a big development in the diagnosis. In early 90s, I conducted a study by doing bronchoscopy and testing PCR for tuberculosis in All India Institute of Medical Sciences. Was doing bronchoscopies for, it was a sort of coded study, and which was negative. And in 95, the American Thoracic Society said that PCR should not be used for the diagnosis. But as of today, this has become a gold standard for diagnosis of tuberculosis. It's very fast, it's automated. The results are available in less than 2 hours as compared to 4 to 6 weeks. Detects MTB and rifampicin resistance at the same time, and it can be used for CSF, gastric, lymph node aspirate, and tissues. And this shows the sensitivity and specificity of Gene Expert. Now, the Gene Expert Ultra is a further advancement with the higher sensitivity in smear negative patient, and also it is used for extrapulmonary tuberculosis. TrueNet is an Indian invention, and which is much cheaper. It is battery operated, portable, and the results are available within 25 minutes, so within an hour or two. And so therefore, there has been several development on that. And of course, TB lamp is another test. I need to be fast to finish my talk in the next 5-10 minutes. And so various genes are being targeted, like RPO gene, CAT gene, genotype, and so many other things. These are helpful in finding out the drug resistance at a biotechnology level. And we remember that when I started working in pulmonary medicine, there was no backtech culture. The culture used to take 6 weeks, another 6 weeks for sensitivity test by the time the patient would be gone. So now there are ways to diagnose drug resistance in time. Now, this is another development that is not for the diagnosis of active tuberculosis, but for a surrogate of, you can say, Monte's test. And this particular test that we called side-TB test is a next generation skin test, very highly specific for TB infection. Important thing is it is unaffected by prior BCG vaccination status, which is a big confounder when you are wanting to interpret tuberculin test. This is the development which is there. Now, further development has been that you can actually collect only swab. So many of the tuberculosis patients do not produce sputum. So therefore, you can't be doing bronchoscopy for all these patients. So this particular swab collection test is a newer development. Of course, the way of testing is the same, in-house net or commercial net or expert, but this has been found to be used. You can take buccal mucosa swab or tongue swab or gingival swab. Out of this, the tongue swab has been found to be the most active. Talking about the advances in therapy for MDR, that is extremely important. We know that streptomycin came in 1940, and soon it was realized that there was development of resistance to streptomycin. When the PAS came in 1950, both were combined, and then came INH and then pyrazinamide, and rifampicin was a big game changer. When rifampicin came, everybody thought the TB will be eradicated because the regimen was shortened, but it didn't have to happen. Now the 2010 bedaquiline was approved, and then the delanamide, and now we are looking at 6 months or 9 months regimen for MDR tuberculosis. So the groups have changed. This is the grouping of, I don't have time to go into all this. And now the second line group is injectable drug is also put in different group as compared to what we are reading. And group D is bedaquiline and delanamide. So the regimens are a shorter regimen of injectable drug where 7 drugs are given for the first 4 or 6 months and of past. And Agam would know and remember that patients were getting troubled because of getting injection, deafness was there, kidney involvement was there. So those are replaced by oral regimen, and there are shorter regimen, what especially the BPAL regimen. Now the guidelines have changed for monoresistant now that we are diagnosing tuberculosis, and there is shorter MDR regimen. But I want to say that not every patient of MDR TB is a candidate. There are defined criteria for that. And extrapulmonary tuberculosis, because of MDR, is the difficult ball game together. And that is going to be. So there are inclusion criteria for shorter regimen, which are right in front of you. And I think I should not exceed my time. Now, what you call it, new wine in an old bottle, or old wine in a new bottle. We have started using drugs like clofazimine as one of the main drugs. It is a part of the regimen in various trials and TB practical, stream 1 and 2 and B. And clofazimine, which was sort of an orphan drug. But my boss, Dr. Pandey, 30 years back, was very fond of using clofazimine for MDR. At that time, the evidence was not there. Linezolid is another drug which is being used. Good thing is that instead of 1200 milligram, 600 milligram is being used, and it is found to be useful. So the groups have changed, group A and group B and group C, which contains, I need not recite those. And these are the regimens. Difficult to remember those who practice tuberculosis, and I must say that I don't have access to this regimen. These are given by only TB centers who are approved for this. So there's another concept which has come, which I want to share with you all. That is concept of subclinical TB. Why this concept has come? Because if you want to control TB, you have to diagnose all the cases. And we know that there is a lag period of 4 years from development of symptoms to diagnosis of TB, but that's not what I'm talking about. Subclinical TB is the one which is not latent tuberculosis, it is active tuberculosis, but patient has no symptoms. So these patients keep on transmitting infections. So how do you pick up these people? How do you select these people? You cannot be testing 140 crore people for tuberculosis to pick up all the cases. So do you use tuberculin test or an interferon gold test to pick up these subclinical tuberculosis, or you focus at the people who are undernourished or those who are immunocompromised? There are no studies to give us that idea as to how to pick up. Unless you diagnose subclinical tuberculosis, you cannot control tuberculosis, because these are the people who would be, without knowing that they have this disease, will be transmitting the disease, and someday they will present. So this is the incidence of subclinical tuberculosis, which is uh, present. I don't have time to go into 50%, 56%, 49%, and 39% cases found in Tamil Nadu TB survey had no symptoms. These are the people who have subclinical tuberculosis, and the policy maker have to think about as to how to go about it. So, role of finally, is there a role of artificial intelligence? That is my last. I think something wrong with my slides. The artificial intelligence is being used in big way in all walks of life. So there have been studies where even the recording of the cough can lead to the diagnosis of tuberculosis. The X-rays can be done with a handheld X-ray machine, and that can be read by the AI, because it's not possible to have radiologists or doctors all over the place. So ladies and gentlemen, sorry, something wrong with my slide. So anyway, so what I want to say at the end, on this day, 24th March, which is commemorated as World Tuberculosis Day, the advances are too many. The short-term regimen for MDR TB, and also there are studies to shorten the regimen from 6 months to 4 months. The previous study done at Hong Kong unfortunately failed, but more enthusiasm is there to shorten the regimen. The newer drugs are coming in slowly, though. Old drugs are being used, but the important thing is the public health and epidemiology. The mortality rate in developed world is minuscule, and we are just reducing our mortality by 10% or 15%. So there's a long way to go. It's not only the medical fraternity, it is the policymakers and also the public at large. The awareness is most important, and I'm looking forward to a vibrant panel discussion. And I thank Dr. Sangram brother and all Dr. Paul and all the senior physicians for giving me this opportunity. Thank you very much.
Good evening, sir, and that was fantastic presentation, as expected. From teacher's teacher, Dr. Khilnani, sir, a fantastic overview of past, present, and future of tuberculosis. I'm sure we now know 130 years of your knowledge of the bug responsible for development of tuberculosis, and that is Mycobacterium tuberculosis. More than thousands of years of knowledge about disease, some disease, which now we know as tuberculosis. More than 8 decades of treatment, 15 years of newer test, ever evolving test, and still TB continues to kill. It kills. By the time we finish our discussion, maybe hundreds of patients would have died across the globe because of the single bug, TB. We are at the best situation today. with best available knowledge about tuberculosis, with political will to help you eradicate tuberculosis. Eradication is anyway far-fetched thought, but yes, we can end TB, and that's the theme for World Tuberculosis Day 2025. And the extension last year also, this was the theme that yes, we can end TB, but today, this time we've added commit, invest, and deliver. And at API, we are really committed with your help, because you and me individually cannot do anything unless we join hands, unless we come together, and unless we stimulate society. These goals are really easily achievable. I've got fantastic panel with me, and I've got Khilnani sir also here with me. And to begin with, I would start asking these questions by asking my first question to Dr. Harikishan. Today, I'm likely to restrict my discussion to mainly drug-sensitive tuberculosis, when to suspect drug resistant, how to initiate, because I feel that treatment of drug-resistant tuberculosis must be handled at consultant level or at specialist level. I would request, and if one message I can give you through this discussion, through this 1.5 hour of time investment that you're doing, please do not try to manage drug-resistant cases at your level. Refer them to specialist. Harikishan, my first question for you. Are you there? Yes, I can see you there. Harikishan, a lot of confusion regarding physician colleagues, my friends, when they talk to me about treating a drug-sensitive case of tuberculosis. You have that pleural effusion, you have a cavitating lesion, you have meningitis, you have orthopedic lesion, a spine lesion. And as of now, the current guideline talks about treatment of 6 months. A lot of them are not happy with 6 months treatment. They would want 9 months treatment, a year's treatment. Your views on that?
But I think the guideline recommendation is only 6 months. So there is no, like I cannot recommend to
Absolutely
the treatment, but in some certain cases, like if you have a neurological TB where patients have meningitis, and some cases even when you have endobronchial involvement also in some cases when the disease is not that endobronchial, we mainly deal with airway related tuberculosis.
Absolutely.
So in some cases we also use those 9 months regimen.
I can see your passion for IP.
But that's only
you think about endobronchial tuberculosis first. Yes.
But I think it is a time like these national bodies also make some recommendations of including endobronchial tuberculosis management also as a guideline, because if you see, none of these guidelines have any recommendation on when to do screening bronchoscopies in
Absolutely interesting.
If you see bronchoscopic incidence of endobronchial TB is around 40% in newly diagnosed patients, to a range from 60% also in some countries.
Okay.
I think in some cases it is recommended. And coming to your question on extending treatment, I think the guideline is only currently recommending 6 months. So I
Absolutely
cannot give a personal statement saying that you should extend treatment. Maybe some cases are clinician based diagnosis, like if you
Absolutely
think that
I completely agree. And the message that we got it from this discussion is treatment of tuberculosis is 6 months, drug sensitive tuberculosis. Whether if it is specially spine tuberculosis or extrapulmonary tuberculosis, trust me, it is even paucibacillary disease. And chances of drug resistance otherwise would be even less. You don't continue treatment for that pain and for that disfigurement or for that minimal fluid which is still there on sonography. It should be 6 months only. Certain physicians would prefer giving it for 9 months or a year, especially when it is neurological tuberculosis, some serious forms of tuberculosis. But I, in my personal capacity, would request you to refrain from doing so. Continue treatment only for 6 months. And Samir, that makes me ask you next question. When would you suspect drug resistance? You have a patient, you put on treatment, and patient does not respond. When would your personal feeling be there, or when would you recommend to investigate further? When would you call that patient is not responding?
No, I think it's a very practical question as well, because now a lot of times, typically what we see, okay, some patients are being referred to us who've been on drug-sensitive TB regimen for almost 18 months to 2 years, for whatever reason, without suspecting multiple, some say drug resistance or whatever. So the idea is any patient who is clinically not responding, radiologically not responding, and microbiologically not responding. So when a patient comes to you, say I put you on a drug sensitive regimen, sent for tuberculosis, the patient continues to have cough, the patient continues, this is at the end of 2 months of your intensive phase. At that point of time, of course, it's important to review your microbiology, because if the patient is not responding, that is number one thing for me. Okay, I will do the test for this particular patient. Second thing is always, whenever we are doing the tests, now this is where I think even the guidelines say that you should send microbiology in each and every case, but still we lack here. Sometimes we do not really send those gene experts. We do not really, especially in cases of extrapulmonary tuberculosis. Now, this is one of the reasons, because in extrapulmonary tuberculosis, there is a lot of chances of paradoxical responses also. So we get referred a lot of pleural effusion cases who, despite being treated, the pleural effusion increases and then ultimately, and maybe lymph node TB cases. So in all cases, whenever clinical response is not there, your person starts having increased symptoms, the fever doesn't go, that is when you should suspect that my patient may be having drug resistance, and you should get those
Excellent.
tests done.
Excellent. The point to learn from here is there could be a paradoxical reaction as well. So you have a lymph node there, you put them on treatment, and there may be paradoxical increase in node. It may be clinically very difficult for you to differentiate whether it is treatment failure and the lymph node is increasing because of there is drug resistance, or it is actually treatment working. There's a lot of killing going on, there's a lot of inflammation going on, and that's why lymph node is increasing. This requires clinical art. If your patient has got constitutional symptoms improvement, if this patient has got otherwise parameter improving, that fever is gone, that constitutional symptoms have gone, there is weight gain, do not be in hurry to judge drug resistance. And if it is increasing, that means there is liquefaction there. If you did not have chance to investigate that patient earlier, this may be your best chance. You can definitely aspirate material from there and send it for all possible tests. What Khilnani sir said, there are gene expert available which gives you answer on the same day. There is a newer advancement to the test called Gene Expert Ultra, which gives you even quicker response and it picks up even lesser number of bugs. And then you have other tests which helps you judge INH, fluoroquinolones, and the aminoglycoside sensitivity at the same go. So you ask for line probe assay 1 or 2, or you ask for Gene Expert XDR, and you would know that. And hence, at this stage, for you not to ask for investigation will not be accepted. Dr. DP Singh, are you there? In many situations, you may have. I don't see Dr. Is
Yeah,
Dr.
he's there.
Singh
He's there.
Yes,
He's
yes,
there.
yeah, yes.
Okay. सिंह साहब सर आपने तो आपकी नजर के सामने इवोल्यूशन ऑफ ट्यूबरकुलोसिस देखा है आपकी नजर के सामने आई एम श्योर यू वुड हैव सीन दैट वी वर फोर्स्ड टू पुट पेशेंट्स ऑन ट्रीटमेंट sputum not producing, CT scan not possible, and now you've seen days where all possible tests are available at a click of a finger and they are available for free most of the times. Government allows the gene expert to be done free, CT scans to be done free, drug resistant evaluations to be done free. Do you see in today's time, आज की तारीख में, do you think you will put somebody on empirical treatment? Okay, you would put all your money, all your efforts to come to conclusion, would diagnose tuberculosis and then only initiate treatment? Dr. Singh.
That's a very good questions, very nice questions. I would say that, in the clinical practice, we are taught, we are teaching for last more than 40 years that whenever anybody having cough for more than 14 days, especially for the chest tuberculosis, put the patients on sputum for AFB, sputum for CBNAT, get the diagnosis done, get the treatment. So anybody, any MBBS doctors can get and treat it. But the patient is not producing sputum. And in that case, not everybody can be sent to the higher center to get the bronchoscopy done and get the samples of ball and confirm the diagnosis of this CBNAT. But in that case, yes, the clinical diagnosis will be there. A clinical diagnosis, and we think that patient is having fever, patient is having weight loss, patient is having other symptoms, in the especially the pulmonary tuberculosis. But in the extrapulmonary tuberculosis, that
Yes.
that is a possibacillary disease, and that site may be inaccessible in those areas. We are not going to put this samples are not available. In that case, there are many such cases where empirical
Yes.
treatment we have to put, and there are many cases are coming, the fever more than 2 months. This loss of weight and other things, HIV is negative, other things are negative, and we are not getting to pinpoint the diagnosis that it is tuberculosis or something like that. But
Absolutely.
always remember the Crofton's, Sir Father Crofton, if you are not getting any diagnosis, you are thinking clinically that it is tuberculosis, never allow a patient to die without giving the trial of 7 days or so for
Excellent.
plus twice.
Mhm.
Yeah.
Lovely statement. Absolutely. So what Sir says, you will face situations where you may not find the correct answer. If possible, do investigate them in detail. And today, even PET CT scan is available. You can ask for PET CT scan to find out which part of the body is involved. If you're not too sure whether it is where you don't pick up anything in lung, this may be a situation. But there are times when, in spite of all possible investigation, you may be at loss. When it comes to abdominal tuberculosis, when it comes to genital tuberculosis, you could have difficulty in diagnosing. If you clinically feel, you may initiate this patients on treatment. But I have a request. You will come across many situations where they may have even connective tissue disorder. You will come across many situations where they may even have hidden malignancy, and this may be paraneoplastic presentation. You may come across various diseases. I've recently had a disease with head scratch, a lymphadenopathy. It was diagnosed as it was clinically diagnosed as tuberculosis. Patient was put on treatment, and when eventually we went further into it, we realized patient had a cat, and that was a granuloma because of cat scratch. So you have variety of diseases possible. Having said that, Khilani sir, what is the role of empirical treatment? So Singh Sab said okay, you can put this patient on treatment and reassess. How long would you recommend if you put somebody on empirical treatment?
Agam, I wish you did not ask me this question because there are no answers. Answers will depend upon what setup you are working. So the setup, I work in Delhi. I have all the gadgets, all equipment, all CT guided
Correct.
biopsies and everything. So I don't remember in last 1 year or so that I would have put anybody on empirical treatment because I have access to all kinds of investigation. But having said that, I completely agree with completely 200% I agree with Dr. Singh what he has said. Amazing expression of the question that you have asked, that if there's a situation that patient has clinico-radiological suspicion of tuberculosis and you have not been able to achieve a microbiological or histopathological diagnosis, you can't leave the patient to die. And there is, after all, I'm also, my age, you can make out that we have treated patients empirically with anti-tuberculosis, even at the All India Institute of Medical Sciences. And within 3 to 6 weeks, the fever comes down, patient starts putting on weight. So, in fact, the studies that we conducted under the guidance of Dr. J.N. Pandey on tuberculosis, response to treatment was considered as a diagnosis of tuberculosis. The paper which was published in Thorax on hepatitis, it was one of the criteria for diagnosis was response to treatment. It still holds true for everybody in India and everywhere. That's my opinion.
Absolutely. So it's like any physician, when there is malaria suspicion, and if your smear MP is negative, you would put them on empirical treatment for anti-malarial. That is what Sir is saying. You do put them on trial of treatment if you clinically suspect tuberculosis. I'll give you a scenario.
But, Agam, can I say something? Agam,
yes,
I want to say something. That in today's era, we are Americanized, especially in cities where the legal medicine is also important. Whenever you put the patient on empirical treatment, it should be put on record that you are doing it empirically.
Absolutely. That's a fantastic point. You must document that this is empirical treatment after discussing with patient, after giving them the option of further investigation, you're putting them on treatment. Having left legal aspect aside.
Dr. Agam, I always ask the patient whether I will put you on anti-tuberculosis.
Absolutely. That's a fantastic way.
Always. Because nowadays, anybody can sue you.
True.
Oh,
True.
why you have put the without the diagnosis? Anybody can file suit.
Absolutely.
The
So,
people are
friends,
very
you have a
aware.
legal challenge,
Yeah.
you have a clinical challenge. We'll
Yeah.
leave legal part of it aside. But
You
if there
have
is a
to
clinical
take them
challenge,
into confidence before you start the anti-tuberculosis study.
true.
Everybody knows
You
it.
can put them on trial of treatment, but
Yes.
whenever you're putting them on trial of treatment, mind you, use only first line drugs. Use only INH, rifampicin, ethambutol, and pyrazinamide. Do not give any other drugs than this drug. When you're putting them on this treatment, do monitor them for side effect. First 7 days, you will ask for liver functions and monitor for other side effects, and you can continue only for 3 weeks. I would give you liberty to do it for one more week, make it 4 week, 1 month treatment. If your patient does not respond at the end of 1 month, please do not treat them further with empirical treatment. Because at that stage, if he does not improve, once you label them as tuberculosis, he will be put on drug resistant regimen and the treatment will go completely haywire and you will miss diagnosis. And I would suggest you may do so in clinical dilemmatic situation, trial of treatment or empirical treatment for 3 to 4 weeks. But when it comes to no response at the end of it, do not hesitate in jumping to further investigation at the end of 1 month. With that, Dr. Harishankar, you did mention about invasive procedures. Tell me what kind of situation, what kind of clinical situation would you recommend, or do you feel this patient must be referred for bronchoscopy?
To me,
Harikishan?
yes, sir. Can you hear
Yes.
me?
I can hear you, but I cannot see you.
Yes, yes. My signal is a bit weak, sir. So,
Okay, fine.
one is the procedures that we offer for one is for diagnosis, because now in the panel discussion we heard that some of the senior doctors saying that we cannot refer all the patients for bronchoscopy. That is true, but bronchoscopy should not be considered as an invasive diagnostic test.
Absolutely.
It's a very basic
Very simple test. Yes.
Yes. So in patients who really need that, when your smear is not coming positive, but clinically, if you still suspect that patient can have TB, I think all those patients, if your center do not have a bronchoscopy, you should send them to the nearby medical college or somewhere where they can provide. So diagnostic aspects, this is mainly one thing. And especially in extrapulmonary tuberculosis, actually the need for empirical treatment is more in cases of extrapulmonary TB, in my opinion, because many a times smear positive TB in cavitary disease, all those things are very straightforward. But when it comes to mediastinal nodes, even the diagnostic accuracy of the tools what we have, like EBUS, TB, and NDA, they're not as good as in those patients with a cavitary pulmonary cox or something when you test their smears for AFB. So I think that there is a very thin line between even sarcoid and TB. Many patients we also
absolutely yes
do. So that is one area where we do diagnostic procedures for differentiating between TB and sarcoid also. So these are some of the, and coming to thoracoscopy also is one diagnostic aspect where you have a pleural effusion, because that is one area where we see many malignant patients are being treated with anti treatment. And again, thoracoscopy should be considered as a very minimally invasive, simple daycare procedure. So you should offer the patient these kind of procedures, what they do. The most complicated interventions that happen during TB management is the left main and the right main bronchial stenosis due to endobronchial tuberculosis, because there is no clear criteria on how you manage those patients when you do bronchoscopy, because these happen in very young patients, productive age group, but symptoms are not very straightforward. Like you don't have much clues on the X-rays or CT scans that the patient is developing endobronchial TB. By the time, because most of the symptoms are like a complete collapse of the lung, then you start doing something and then you land up not able to cure those conditions. So these are the basic interventions.
So friends, what we gather from Dr. Hari Kishan is there are 3 tests available. One is bronchoscopy. Trust me, this bronchoscopy is extremely simple procedure. This bronchoscopy does not even require hospitalization. This bronchoscopy does not have many prerequisites. It can be done under local anesthesia. Most of the centers, even anesthetists are not required. We do it under sedation. Maximally, you give about 1 or 2 milligrams of midazolam. And in fact, if you may not do that, you may give it under 4% lignocaine nebulization, that is also done. Of course, the practice is changed from center to center, and patient probably would be discharged in less than 1 hour's time. The only complication that you see commonly in practice is hemoptysis. So whenever you take a biopsy or a washing, there may be some laceration of upper respiratory tract or some cord edema, and there may be some hoarseness of voice or some hemoptysis, and that to remain for some time. That's about bronchoscopy. Fluoroscopy also is done, or thoracoscopy is also done under local anesthesia, and that also does not require long admission. It may be done in just 1 day time. It may require intercostal drain to be put after that. And the third investigation that we have now is EBUS, and that is endobronchial ultrasound. The situations where you would need such procedures to help you in diagnosis of tuberculosis would be endobronchial tuberculosis. So when your patient is excessively coughing, disproportionate cough, you would think in terms of endobronchial lesion. When there is hoarseness of voice, you would think in terms of mediastinal lymph node, etc., which are pressing upon trachea. When there is disproportionate breathlessness, do think about this. Do ask for CT scan chest, and you will pick up that. And when you scope them, you realize you pick up various things. You pick up endobronchial ulcers, you pick up lymph node which are rupturing into the trachea. You may be able to sample tissue very easily, and you may be able to subject them to different tests, which gives you answer in no time. Thoracoscopy also, many a times we get the exudative pleural effusion with little borderline or little elevated ADA, lymphocytic predominance, and your closest differential is malignancy. If your gene expert is negative, if your cultures are negative, do not hesitate to put these patients under these procedures. So I would recommend that you put them on treatment for about a month or so. If this patient does not respond, if the pleural effusion does not go down, or if it recurs, probably you're talking in terms of malignancy. Samir bhai, having said that, you have this sputum taking little longer time for cultures. So when you put this sputum for culture, it takes about 4 weeks, 6 weeks. And are there any newer culture techniques available? Your molecular test will talk to you about rifampicin, INH, quinolone, and maybe injectable aminoglycosides. What about other drugs? Do you rely completely on the molecular test, or you would want cultures also? If culture, what are the advancement in cultures?
I think absolutely, because I think, yes, there have been a lot of advancements in molecular technology. And in fact, nowadays, as you were also talking about this expert XTR, so we have also made it standard practice because we have it available with us. So a reflex testing. However, the gold standard would still be this phenotypic testing, because again, it is, I mean, because culture-based and reflex testing based on the cultures, and it can give you at least 13 to 18 drug sensitivity testing. Now, of course, the major limitation with culture and DST has always been the turnaround time. Because first your culture, okay, if it is sputum smear positive, may take about 2 weeks also, you can get culture positivity, or it can take up to 6 weeks also. But then drug sensitivity further takes about 3 weeks. The whole thing is with all these liquid cultures and the MGIT system, with the growth indicated tubes, it has become so simple nowadays. I mean, it is at least, it has saved, if not more, at least 4 to 6 weeks from that turnaround time. So that has really been well. Now, I just want to put another thing in addition over here is the whole genome sequencing. I know it's not widely available. I know it's maybe it's not really there in the program yet that you can get it for free of cost. It's a little on the expensive side, so not anyone can get it. But that's another option which is available, which gives you a lot of information about the whole sequencing of it. And now the next generation sequencing is also coming in big time.
True.
So multiple things are available which are coming into the pipeline. But definitely, I would say when it comes to culture, that is still the gold standard. Because if you have any doubts that whether a patient is sensitive to a particular drug or not, your go-to choice will be your culture DST, the phenotypic DST.
Absolutely. So Samir Bhai has given crystal clear explanation that you must ultimately rely on your cultures. To tell you and to confuse you more, friends, your gene expert could remain positive for a longer time. Suppose if your patient had tuberculosis, a cavitated tuberculosis, and this is gene expert positive, he is cured of disease, but this cavity may shed those dead bacilli. this dead bacilli, if you happen to test for tuberculosis for one or the other reason, could be there, and it could show the same sensitivity pattern. In the sense, if the patient was initially sensitive to rifampicin, it would continue to show you sensitivity to rifampicin. In that situation, you may have clinical dilemma. Here, only two things. If the sensitivity pattern changes, or if culture is positive, then only you can conclude reactivation, relapse, however you may say, of that particular disease, and hence sputum AFB culture sensitivity is the gold standard. We've got a lot of advancement in this culture, as Samir Bhai was saying. There are liquid cultures available, which gives you result little quicker than what was earlier. And you can even pick up those cultures colony for molecular test and pick up rifampicin and rest four things sensitivity based on the culture. So you know that this definite bacilli, this is growing, that means it is a live bacilli, and you can do molecular testing on that to get your sensitivity pattern a little quicker. With that being said, what are the different extrapulmonary tuberculosis that you're seeing? Dr. DP Singh, we were talking about a lung TB, and we talked about lymph node TB. We did speak about pleural effusion.
Dr.
I'm
Agam,
sure you would have seen.
DP Singh has gone for other meeting.
Oh,
Probably has left. Yeah.
Oh, okay. So we have Khilnani sir.
Yes.
So Khilnani sir, I'm sure you would have seen all possible organ involved
Yes,
in
sir.
tuberculosis.
Repeat your question, please. Sorry, please
Sir,
repeat your.
what different organs you have seen getting involved in tuberculosis? When I talk about extrapulmonary tuberculosis, we did say pleural effusion and lymph node TB and spine TB. But is there any organ of your body which does not get involved in tuberculosis?
Except for nails and hair.
Nails, yes.
Every
Friends,
organ can be involved.
Your eyes can be involved, your genitourinary system can get involved, your bones can get involved, your omentum can get involved, your ears can get involved. Think about the organ and you can have tuberculosis of that organ. And sir, extension of the same question. Would you enlighten us on this typical versus atypical tuberculosis? What is this MOTT and different terminologies we have? How common you see?
What is
Yes, sir, atypical tuberculosis.
You mean mycobacteria other than tuberculosis?
Yes, those rapid growers and mycobacterium post you see in.
So now with the advances in the microbiological diagnosis, we are diagnosing atypical tuberculosis or mycobacteria other than tuberculosis more often. In my practice, since I practice pulmonary medicine mainly, so whenever a respiratory sample, be it sputum or ball, if it is a smear positive and gene expert negative, my eyes are open for atypical tuberculosis. And then the culture generally helps us. And now there are biotechnological based tests are also available. But my experience is mainly with the culture, where I have diagnosed all kinds of rare forms of mycobacteria other than tuberculosis. Usually the presentation is not with cavitary tuberculosis. Quite often these people are immunocompromised, whether known or unknown. So whenever there is a atypical form, mycobacteria are there, we look for immune deficiency also, but it's not always there or always not found out. And then the treatment is more prolonged, more difficult. And I must admit that if I find a atypical mycobacteria, I have to go back to the book and find out the regimen. The regimens are different for each mycobacteria, which are difficult to memorize. At least I don't remember them.
True.
And
True, absolutely.
the results are gratifying.
True.
To diagnose it, then
So friends, many a times you will come across a situation where you have AFB positive and you ask for gene expert and gene expert turns negative. So when you have such situation, this could be atypical mycobacteria. By atypical mycobacteria, we mean they're not typical Mycobacterium tuberculosis. Their disease behavior is different. Their response to treatment is different. You will see atypical mycobacteria mainly in immunocompromised situation. You will see atypical mycobacteria in advanced AIDS patient. You will see this kind of disease in older tuberculosis or fibrocavitary disease, which gets atypical bugs. Or commonly now I'm seeing this with post-operative wounds. So if your small setup, small nursing homes are not adequately fumigated, this mycobacteria would infect that wound, and you will have those post-operative patients having pus discharge from there. They have received multiple antibiotics. The cultures are regularly negative, asked for bacterial cultures and anaerobic cultures. And when you happen to send it for A/B culture, you will pick up different bugs. So you may have a rapid growers there, or you may have different kind of mycobacteria there. And as Sir said, it would require different regimes. It would require longer regimes. It may require injectables. It may require linezolid. It may require clarithromycin. It may require rifabutin, and treatment goes on for a longer time. In fact, there are situations where they may not get eradicated ever, and they may continue to remain there. And this becomes a tricky situation. You will have to probably consult your pulmonology colleague or ID specialist to come to conclusion. With that, Haribhai, do I ask you this next question about, would you enlighten the delegates about interpreting this gene expert report? So I get confused when I see this gene expert report. It says low, then it says sensitive, it says intermediate, it says inconclusive, it says resistant. Would you tell us how do we interpret this report? Dr. Harikishan.
Yeah, the only problem during interpretation what we have is with the Gene Expert Ultra platform, when it shows that Gene Expert is trace detected, many a times you see the rifampicin resistance also in that. So that is one situation where we have to clinically judge whether this is actual tuberculosis or not in those patients. Though they say that the machine sensitivity is too high, but we do get these reports.
Absolutely.
Who actually do not have tuberculosis clinically and radiologically also. So that
Absolutely.
is what.
Absolutely. So friends, whenever you have this reported as low, in that case, the test or the reverse transcript is what test it is called as RT-PCR, polymerase chain reaction. It may not be able to generate that kind of sequences, and it may not be able to give you the right status of rifampicin sensitivity. And hence, whenever it is reported as low, you may have to take clinical condition into consideration to diagnose the tuberculosis, and you cannot rely on the sensitivity report, and you have to wait for culture sensitivity report for sure. So that is what was the discussion happening earlier, that molecular test would help you. Still, gold standard would be cultures, and you have to finally rely on cultures only. With that, yes, Khilnani sir is making a statement.
If it is low, it is still it is tuberculosis. If it is trace, then it needs to be repeated. You cannot
Okay.
take it as fault.
Okay, so interesting point. You may repeat those tests, and you know, rather than jumping to other tests, this repeat test could also give you answer. Samir bhai, what about drug reactions? What kind of drug reactions do you see when these patients are initiated? We are talking about only first line treatment, huh? We are talking about INH, rifampicin, ethambutol, and pyrazinamide.
So I think another very practical question, because this is something which I'm pretty sure everyone encounters. Now, if we talk about drug reactions, one of the most common things that everyone possibly sees is transaminitis, some elevation in your SGOT, PT, or ALT, AST levels. And that is also acceptable to some account because of isoniazid over there. Now, what we see many a times is, okay, it is slightly elevated. Also, people stop the regimen and then they refer to us that there's been a drug-induced liver injury. But everyone's got to know some amount of transaminitis is expected. It's only when we have more than 3 times upper limit normal with symptoms, or more than 5 times upper limit of normal, is when we consider causing, it being a drug-induced liver injury, and we consider changing it. Second thing that we see, whenever I would like to interrupt the therapy is, the drug eruptions. Now, off late, why I talk about drug eruptions is, off late, I've seen at least 3 of my patients having drug eruptions to rifampicin. So this is another category wherein you may, and it can happen to any of the drugs, but with rifampicin, it is slightly more common as compared to the other tuberculosis anti-tubercular drugs. So that is another situation where you may have to interrupt the drug, stop the drug, and put that patient on maybe a modified regimen or something like that. Third is the idiosyncratic reactions, when you have a significant amount of rashes out there. And these are situations which can actually be with high mortality unless you treat these patients with maybe steroids. And, reintroduction also has to be very careful in these situations. And of course, all the other reactions that we talk about very commonly, peripheral neuropathies or, the ophthalmic toxicities, and how to monitor or how to modify in case of renal injury. So I think the list goes on and on, but I think these are 3 or 4 conditions which specifically we need to identify or keep in mind, because these are the most common ones which can lead to modified regimens and interruption of the regimen in certain situations.
Fantastic. So, friends, you will come across, you must educate your patients about side effect, must inform them about all possible side effects, because if you don't, the next day family would come with that red color, yellow color, orange color urine complaints. These patients, everybody will get gastritis. Most of these patients may have transient rise in OTPT, which settle down in most of the situation. They may also complain about peripheral neuritis. They may complain about gastritis. Most of these side effects settle down over next 7 to 10 days. I have a habit of asking for liver enzymes after about 7 days. And once they settle, generally there is no need for regular monitoring of liver enzymes. With that, Dr. Khilani, Acha, you have a comment. Dr. Khilani wants to say something?
2 comments. One is that as per the data, 10% of the patients on ATT will have some kind of skin reaction, itching or redness. That needs to be managed with antihistaminics. My comment is mainly about rise in uric acid because of the pyrazinamide. And 20 to 30% patient will have rise in uric acid, and people get alarmed. Everybody will read reports. So we recently finished a prospective study on hyperuricemia with antitubercular drugs and its correlation with the joint pains. Because physicians have a very low threshold for starting, Debutas and allopurinol, and they itself are very gastric irritant. And very few people actually get joint pain. I realize that some of the joint pains can be incapacitating. So I wanted to find out whether there is a correlation with level of hyperuricemia with joint
Absolutely.
pains. Unfortunately, there is none. Or fortunately, there is
Absolutely.
none.
So
So when I
fantastic
follow
point.
these patients with uric acid, unless these patients have concomitant joint pains, I do not treat this hyperuricemia unless the uric acid is 13, 14, 15. Sometimes I get scared because the joint pains can be incapacitating. So this study has just finished. So I just wanted to
Excellent. So, friends, take home message from this discussion is do not treat reports. If your patient has got no arthritis, if your patient has got no joint pain, if this patient has got no stiffness, there is no need for treating this uric acid elevation. This is transient, and most of the times it settles down. There may be other situation. This patient may complain of severe myalgia with normal uric acid, and that is also possible with AKT. Again, that also settles down, and all you may have to do is subject them to little low dose of paracetamol, and this will be taken care of. Your acidity, gastritis must be managed with proton pump inhibitors if you like, but do not continue proton pump inhibitor indefinitely. Most of this time, 7 to 10 days, it will settle down. The last thing is about hepatitis. If your patients develop hepatitis after about 7 or 10 days when you ask for this OTPT, OTPT could be 3 to 4 times the normal, which does not require any treatment, and you may safely continue treatment provided patient is not symptomatic, provided bilirubin is not high. If you have high bilirubin associated with increase in OTPT more than 4 times, then yes, you may have to stop culprit drugs. The culprit drugs could be INH, could be rifampicin, and could be pyrazinamide.
Sorry. I want to say something. If you are giving PPIs, please don't give it with rifampicin in the morning. Make it a point that they take it before lunch or before dinner.
Okay. But when you suppose if your patient develops hepatitis, you may have to stop INH, rifampicin, and pyrazinamide. You may continue ethambutol, but we don't treat tuberculosis with single drug. And in that situation, you may have to add 2 more drugs. You may add a quinolone, levofloxacin, or you may add 1 aminoglycoside. You monitor your liver function test maybe 7 to 10 days, and once they normalize, you may add one after the other drug. You may challenge body with half the dose, and trust me, in 95 patients out of 100, they would be able to tolerate first line drugs. I would urge everybody to make enough efforts to give them first line drugs. Only in situations where you are unable to do so on multiple occasions, only then switch to second line drugs. Once you are able to put all 4 drugs together, you may remove the 2 drugs, that is quinolone and aminoglycoside, that you've added for hepatitis, and continue them on 4 drugs. You will count day 1 when you have given all 4 drugs, and the initial phase is counted as induction phase. You continue 2 months of treatment after that. Having said that, there are some questions in the chat, and I've got Dr. Abhay Singh Devra asking me a question. What's your opinion about eradication of TB from India? It's everybody's dream. I wish, hope, and pray that tuberculosis is eradicated out of this country. Eradication, as of now, looks a far-fetched dream because, as you are aware, tuberculosis bug have a typical capacity to lie dormant. They can lie dormant for a number of years together, decades together, centuries together. And whenever there is a favorable circumstance, that means whenever there is unfavorable immunity, they can reactivate. As of now, we have no drug which acts on this dormant bacilli. Your AKT would work only when they are sexually active or only when they are dividing. Only that is the time. To kill a dormant bug, we have no treatment, and hence probably eradication of tuberculosis for next 50 years at least would be a far-fetched thought. But even if we can end TB, and by end TB we mean we come to a situation where it's no more a public health problem. There could be sporadic cases, but the deaths because of tuberculosis are prevented, and access to the best quality drug is given to all these patients is what is the vision of our Prime Minister. We have Dr. Sandana Naik asking a question. Private practitioners are moving away from managing tuberculosis. Many of them simply refer to government setup. There is a need to involve them. Yes, and there is some mistake from the programmers as well. There was initially a threat came that if you don't notify, you can be jailed, you can be put behind bars, you can be punished, and etc., etc. And that led to a lot of repression. A lot of physicians decided to send those patients to government setups. Yes, but I think those things are rectified. Now there is a fantastic public partnership program going on. If you're interested, you will be given complete free treatment boxes with you per patient. You will be given access to free sputum gene expert test. You will be given access to free CT scans, X-ray test, whatever investigations are required, you can do that. And hence, do not go away from managing tuberculosis. Primary tuberculosis, drug-sensitive tuberculosis, initial tuberculosis, we need you. Unless you join hands with us, we cannot end tuberculosis. Dr. Veerbhadra Chiniwala has said, please enlighten about diagnosis of extrapulmonary tuberculosis, mainly the abdominal and genitourinary. Dr. Harikishan, would you want to take that?
I don't treat such patients.
Oh, interesting. I can ask Samir Bhai, would you say that?
So no, so we do see a lot of these cases because ultimately everyone gets referred to us. So yes, in terms of abdominal TB, because many times these patients do present with, say, either ascites. In fact, recently only I discharged one with pleural effusion and ascites. And so many a times with abdominal lymph nodes also and unconstitutional symptoms. So whenever you have this, now, if at all possible, please get the CT scan done. And because CT scan can help you a lot. How is that mesentery over there? How is the lining over there? How are the nodes? How do they appear like? And if nothing else, I do understand there may be challenges, but ascitic tapping, I think that is one of the things which can be done. You can do certain tests on that, at least see if it is exudative and fitting in with the other clinical picture or not. You can subject the same thing for cultures also. If you have an interventional radiologist who can do maybe an ultrasound guided biopsy or a CT guided biopsy of those lymph nodes,
Nothing like it.
Finally, we have had situations wherein we could not really, get a sample and ultimately had to subject a patient. Again, it required a lot of counseling. We asked our surgery friends and they could do an exploratory lab and they could find, take some samples from the mesentery and proved it was tuberculosis rather than malignancy. So there are these certain situations where you can find the samples. Now, when it comes to genitourinary tuberculosis, I think the urine PCR test is quite sensitive, in fact.
Absolutely.
So that is one of the tests which can be routinely done, especially if your suspicion is pretty high. Now, another thing which, when you come across males or, fertility evaluation, and for infertility, one of the things which you should always keep in mind is tuberculosis, and try and find that cause, try and rule it out. So ultimately, you have a lot of samples if you wish to. And as I think earlier discussion also mentioned, because in extrapulmonary tuberculosis or your suspicion, yes, one thing should be high, but there's so many differentials. You should try and go for some kind of samples, if at all possible.
Do not compromise on tissue diagnosis. Do not compromise on molecular diagnosis. Do not compromise on microbiological diagnosis is the message that Samir Bhai is trying to give us. Whenever there is primary infertility, whenever there is pyuria, whenever there is frequent urinary symptoms, or whenever there is a lesion in the uterus, or fibroids, etc., whenever there are fallopian tubes, etc., which are beaded appearance on sonography, etc., these are the situations where you may have tuberculosis. There may be cases where they had tuberculosis earlier, and these are fibrosis, etc., the complications of it. In that situation, you will need a tissue diagnosis. A lot of gynecology friends have habits of asking for various tests, which are non-standardized tests, and they would ask for TB gold and whatnot test. Trust me, you cannot diagnose tuberculosis just based on that TB gold test. It is not recommended, and hence please refrain from initiating anti-tuberculosis treatment just based on those reports. We have another question from Dr. Abhay Singh Devra, and what are the guidelines about reinstituting anti-tuberculosis therapy after drug-induced hepatitis? Fantastic. So you have after 7 to 10 days of your hepatitis, you monitor these liver functions again. In most of the situations, they come down, and once they are normal, you can reinstitute drugs. So what I do is I
I think Agam, we have lost the connection.
Yes, I think.
Yeah.
Can I answer this question?
Yeah, please, Killani sir, please take.
So I'll go according to the consensus and guidelines, and I, along under my Dr. Pandey, have worked in this area. So what we do is that we follow them up with weekly liver function tests. Once the SGOT-PT are less than 80, associated with absence of symptoms like vomiting and anorexia and all those things, then we think of reintroduction. Now, reintroduction can be done in three ways rather. One is that you introduce the rifampicin and INH at the same time. If the patient does not have risk factors for hepatitis, which include elderly age, malnourishment, hypoalbuminemia, low BMI, or alcohol intake, or hepatotropic virus positivity, if he is otherwise healthy, then I gather the courage of putting rifampicin and INH at the same time, but the chances of developing hepatitis are 10%. If the person has any of these risk factors, then I put them first, start one drug, which could be INH or rifampicin, wait for a week to 15 days, keep doing LFTs. If the LFTs remain normal and the anorexia is not there or vomiting is not there, then I add another drug. Unless now what I'm saying is my personal view. If the person does not have a severe form of tuberculosis like bone tuberculosis or meningeal tuberculosis, or he has just pleural effusion, then I do not add pyrazinamide. I continue with the quinolones for the rest of the therapy instead of pyrazinamide. In a severe liver disease or somebody who has a chronic liver disease, or cirrhosis of liver or decompensation, such kind of patients I see in the hospital where I am working after leaving All India Institute. In those cases, I do start with low doses of INH and then escalate gradually every third day, because these are the patients who have got a very high chances of developing hepatitis and liver failure. Thank you very much.
Yeah, there is one more question Dr. Raghavendra has. Most patients with elevated transaminase, about 3 to 4 times, have anorexia, vomiting, hardly tolerate food and drugs. Do we need to stop TB drugs few days? Dr. Bansal, can you take? Kindly unmute.
Yes, sorry. So I think anorexia, vomiting, these are symptoms only. So that was the gist that yes, if your patient has symptomatic transaminitis, you need to interrupt the therapy. However, up to 5 times normal, I mean, upper limit of normal also, if you have transaminitis, but the person is asymptomatic, you can still continue, but this will require more frequent monitoring of your LFTs rather than maybe monthly or once in 2 months. You can repeat every, say, 5 to 7 days. Again, there is no standard guidelines on this, and keep a watch for those symptoms. So these are the situations where you will interrupt only if the person is symptomatic.
Yeah, I think most of the questions from the chat box have been answered. The only thing, Dr. Agam, we lost his connection. So before we conclude, we would like to have a take-home message from each one of you. Dr. Harikishan, your message to the audience. Kindly unmute.
Sir, my message is in this current era of advanced diagnosis, I think patients most of the patients should not be started on empirical anti-tuberculosis treatments, especially those with pleural effusions and mediastinal adenopathy, and some pulmonary infiltrates on chest X-rays or CT scans. That is one message. And for young population, if you young female population with high risk of developing endobronchial tuberculosis, means those patients who are like 18 to 25 years of age group females with proven pulmonary COX with symptoms more than, even after starting anti-tuberculosis medication, they continue to start having cough and other symptoms. You should suspect endobronchial TB in such patients and submit them for a bronchoscopic examination to prevent bronchial stenosis in such cases. So these are my take-home messages for on this day, sir.
Dr. Samir, your take-home message.
Yes. So I think I do echo Dr. Harikishan's perspective that whenever possible, because now there are so many things which are available, I do understand the geography and the maybe availability at certain places, but whenever possible, always try to diagnose that TB with the sample, because that tissue is invaluable, or that sample is invaluable microbiology. And what we have seen over times, as per the latest NTEP guidelines, the cure rate for MDR tuberculosis has increased from 49 to 60%. For drug sensitive has improved quite tremendously. And the only reason has been increased compliance because of the shorter regimens. And second thing has been better diagnosis. So when you have the diagnosis, when you have the facilities, please make the best use of it. It will really help us in achieving that end tuberculosis or eradicate tuberculosis eventually, maybe at some point of time. So whenever possible, please go for some microbiology.
Yeah, thank you. Sir, Professor Killani, sir, your message.
I'm the one who has talked a lot. First and foremost, thank you very much. And I think we physicians have an onus of counseling the patients at the outset when we start anti-tubercular treatment, to apprise them of the potential adverse effects, because the compliance is the key. The main reason for MDR TB is non-compliance. Every patient wants to be cured. So one of the reasons for non-compliance is disbelieving in the therapy and going to alternative therapy or stopping the treatment. So counseling of the patient at the first time when the treatment is started is of paramount importance, and also going through the literature, the recent literature, the focus for the policymaker, focusing on subclinical tuberculosis is very important for Indian setting. Thank you very much.
Thank you, sir. Thank you for your wonderful discussion. Before we conclude, I request Dr. Vishwanath to propose a vote of thanks. Vishwanath, Secretary. Vishwanath, you are not there? Okay, sir. We will conclude. I thank Professor Killani for sparing your valuable time and for the wonderful talk which you have delivered. Thank Dr. Harikishan also.
Thank you very much. It was a learning experience for me.
Thank you.
Yeah. Thank Dr. Bansal, Dr. Agam Morara, who has done a wonderful moderating for the session. Thank you one and all, and I thank all the delegates who have joined. Thank you all once again.
Good night.
So, good night. Good night. We sign. Thank you.